First, my name is Dr. Hamid Shahab. أعمل حاليا بالمملكة المتحدة كconsultant radiologist. أنا كنت بكندا. بس نقطة صغيرة، أنا طلبت من ال artificial intelligence أنه ينطيني picture of a big wooden chest with some X-rays and CT images arising from it. But this is the level of artificial intelligence now with this pathetic X-ray of the chest. So we'll be good for a while. The artificial intelligence is not that intelligent for now, but we need to catch up. We'll start with the chest X-rays. We have two patients, one with shortness of breath post-renal transplant, and the other one with cardiac arrest with the CPR. So I hope one of the students will volunteer to case.
دكتور أحمد ماهود.
نعم أستاذ.
دكتور أحمد ماهود تفضل.
صباح الخير أستاذ.
صباح الخير.
Doctor, please just start as you usually start with any chest X-ray. I want to see your approach. Please. So this is a 55-year-old female patient who has recently renal transplant and presented with a few days of shortness of breath and fever. Start, please.
ماكو اكسراي دكتور لحد الان ماكو شيء.
تشيس اكسراي ما طالعه. تشيس اكسراي ما طالعه.
Okay. You see the radiant, right?
بس radiant لازم.
Case number 1 chest radiographs SOB وكاردياك arrest مكتوبه بس هذه السلايد. سلايد نمبر 2 يعني.
Try again.
دكتور حمد لازم تنهي هذا الشير والشير الثاني.
Okay.
Okay.
Okay, good. Thank you.
Good. It's an AP position chest X-ray. Show abnormal ratio, abnormal right side opacity, include the lower zone of right chest. يعني with the opacification and opacification of the right lower lung zone. يعني most likely يعني patient history of on renal problem. يعني most likely pleural effusion يعني.
Okay, let's start from the beginning. When you start describing the chest X-ray, you would mention the technical aspect of the chest X-ray. You mentioned the projection.
Yeah.
And are you satisfied with the other factors like rotation? Is there a rotation?
And rotation يعني position مال patient normal يعني like normal يعني.
Yes, okay, it's satisfactory. Slight rotation to the left, but it's okay. What about inspiration?
Inspiration number of inspiration number of ribs يعني good. more than six ribs يعني show. So inspiration view يعني.
Good. Penetration is good. Okay.
Penetration is good. Best obliteration of the right lower zone of right lung.
Okay. What do you think of the
and obliteration of costophrenic angle يعني as a compare with other side of left side.
Okay. What about the airway, the trachea? Is there any?
The airway central position. الهارت أيضا normal position. بس عندنا هم ossification of the right side of heart, right side of the heart obliteration يعني caused by يعني same cause of obliteration of the right lower zone.
Yeah, first we compare the lungs and we see if they are symmetrical. First compare the two hemithoraces, see if they are symmetrical in size, and look at the lungs in general to see if there is any asymmetry in terms of lucency of the lungs. After that, we look for any focal lesion like a nodule or a mass or a focal consolidation.
اكو عندنا اكو هم consolidation يعني اكو هسه شفته بالميدل زون يعني من right middle zone also.
Perfect. Yes.
Yes.
How do you evaluate consolidation? I mean, in terms of determining the location of consolidation.
Yes. هسه عندنا احنا الكونسوليديشن عندنا بالرايت لور زون يعني مسوي opacification of the and obliteration of the right costophrenic angle وعندنا اكو other lesion انه بالرايت ميدل زون يعني بالرايت ميدل زون وعندنا decrease يعني انا قاعد اشوف السبيس مال between two lips يعني.
Yes, when you evaluate for any silhouette sign, you need to track and follow the borders of the heart and the two hemidiaphragms. So on the left side, the border of the heart is fine here.
Fine.
There is no lingular consolidation, for example.
Okay. Yes.
And the hemidiaphragm is clear, so there is no consolidation in the left lower lobe. Right?
Yes.
But on the right side, the right border of the heart is obliterated.
Obliterated, yes.
By the air space disease in the lung. This lobe is
collapsed.
No, it's consolidated, we said.
Okay, consolidated, yes, yes.
Which lobe?
يعني
bordering the right heart border.
Right heart border و يعني right middle and right lower ممكن يعني.
Good. The right middle lobe is here, and there is silhouette sign with the right heart border, and the right lower lobe is silhouetting the
diaphragm.
Right hemidiaphragm.
Right hemidiaphragm, yes.
So there is consolidation involving two lobes.
Two lobes.
And there is, as you said, there is obliteration of the costophrenic angle here on the right side, which means there is a possibility of also fluid in the pleural cavity. Also, there is some opacity here.
Yes.
Probably at the horizontal fissure. Now, I'm going to show you another X-ray only 2 days from this one. Only 2 days difference. What do you notice here?
الليفت سايد يعني بقى نورمال ماكو اي مشكله بيه. هنا عندنا هسه اللي قاعد نشوف اكو فد opacity involving the right upper lobe. زين. Also consolidation, also obliteration of costophrenic angle and of the right side also present, and الفيشر الترانسفيرس فيشر يعني صار obviously clear.
Yes, there's more density within the fissure.
More dense, yes.
Okay, I want you to connect this with this appearance. Where do you think this lesion is?
يعني subpulmonic pulmonary pleural effusion.
Subpulmonic means beneath the lung, but it is extrapulmonic, you can say.
Extrapulmonic, yes.
Yes, either in the pleural cavity or in the chest wall.
Yes.
But as we are in the context of infection, we saw obliteration of the costophrenic angle, increased amount of fluid in the horizontal fissure. So this is more likely representing
pleural بايمة ممكن.
Yes, other loculated pleural effusion from Paima too. Yes, so there's no one. And what do you call this sign when you see the medial border clear and the lateral border is not that clear?
D shape يعني sign يعني هاي.
Yes, it has a wide base on the external side, obtuse angle with the chest wall or pleura, and but here, because it's contrasting with the lung, it's clear, but here, no, there's an incomplete border sign.
Yes.
Means extra pulmonary lesion, either in the pleural cavity or... So the patient's condition is worsening.
Worsening can't have يعني more.
Any other feature that gives you the impression that the condition is really worsening? And the second X-ray here.
اكو radiolucency قاعد اشوف يعني بالapex of the lung of the same side.
Oh, it's okay, but I want to just, it could be, no, it could be about, what are these here? This structure going on other side of patient's leg.
bilateral حاط لها CV line يعني patient referred to
No,
ICU.
just be careful, just slowly, think about it. Where is it coming from and where is it going? Track, you see, this one goes here.
Track هذا.
This one goes here. I think it's oxygen tubing.
Okay. يعني net until.
Yeah. And this is also after 2 years, 2 days after the second one. So here, what happened in this short interval?
اكو لاين هو abnormal line. البوزيشن مالته يعني.
Don't worry about it. Just focus on the hemithorax here.
Yes.
What's the difference between the second X-ray and the third one?
Oh. The third one يعني صاير عندنا right lung complete opacification يعني near complete opacification.
Yes.
وعندنا صاير shifting to the right side.
I mean, look at the trachea. It's like, the spinous processes are like centrally within, projected over the trachea. So
Yes.
there is no really significant loss of volume. Do you know why? So there's collapse of most of the right.
Of the right lung.
This is only the part that's aerated. Why we don't see significant loss of volume?
يعني tubes حاطين في the tube.
No, there's another. We talked about the fluid, right?
Yes.
So there is a pleural effusion, and at the same time, there's increasing amount of fluid and increasing atelectasis in the lung. They balance each other. And so as a result, you don't see much of a loss of volume, right?
Yeah.
Okay. So this is the first one. Just we wanted to have an idea about the approach. I want to show a second case. شكرا جزيلا دكتور.
شكرا جزيلا دكتور.
دكتورة إيناس.
Yes.
دكتورة إيناس فالح.
نعم أستاذ صباح الخير.
يلا تفضل.
نعم أستاذ.
So this patient presented, 66-year-old patient presented with a male patient presented with cardiac arrest and went through cardiopulmonary resuscitation.
Frontal chest X-ray shows there is bilateral.
Before that, please. You said frontal projection, right?
نعم أستاذ.
There is information present annotated on the film itself, the image.
نعم أستاذ، موجود موجود أكو informative film and labeled film AB semi-erect.
Good. So it is AB and it is semi-erect, and most likely it is done through a portable machine, right?
نعم أستاذ.
These are all indications that the patient is not doing well, right?
Okay.
In addition to the great number of lines and tubes you can see, right?
Multiple lines show there's bilateral airspace shadowing, mostly involving the upper and mid part, with the fluid tracking along the major fissure of the right side. يعني preserved costophrenic angle, نشوف إذا there's a rib fracture. There is a rib fracture involving the right lower side. I see.
So
with
what did
يعني
is it the cause of what's happening to the patient?
there's also subcutaneous emphysema.
Yes,
أي.
subcutaneous
أي.
emphysema.
أي.
There is
could be
pneumomodystinum.
trauma, could be RTA, could be
I told you the
CPR.
patient it's okay. I told you the patient had cardiac arrest and then went through CPR.
Yes.
So the rib fractures more likely related to the cardiopulmonary resuscitation.
CPR. نعم.
Yeah, and then there was injury to the pleura, and there is a subcutaneous emphysema, and there's a chest tube right here, right?
Multiple tubes.
Yeah, okay. We'll go through them one by one. But I mean, there's a chest tube with its tip directed towards the apex, which means it was inserted because of pneumothorax, right?
Pneumothorax.
And pneumomedistinum too. There is. So now we established the fact that the patient has pneumothorax, pneumomedistinum, surgical emphysema because of the fracture. I want you to describe each line here and let me know if it is appropriately positioned.
نعم. Start. There's multiple lines. يعني مع ECG من ضمنهن والفيرست chest tube positions in the tip of the thorax.
Yeah, the apex, yes.
نعم. There is لما أجي أشوف أكو there is a CP line or the.
Okay, I'm going to just enlarge a little bit. Try to.
Yeah. نعم. There is a endotracheal tube.
See, in the tracheal tube, there are two lines.
One well positioned above the carina.
Okay, so tell me now, what's the normal position of the tip of the endotracheal tube usually?
Start above the carina about 5 cm.
Good. No. Yeah, I measured that already. It's like 8 centimeters, so it's slightly above. Now, okay, and we said that there are ECG leads, but they're removed like out of the field. So now, what other line you can see or tube you can see here?
I see there's also central line, could be the NG tube.
Okay, this one, right?
No.
You can track it, you know, here.
No, I follow it to the tip of the stomach, and at the opening of the gastroesophageal junction.
Great. So when we follow the NG tube, we need to see that it goes, and I will elaborate it to the X-ray. It bisects the carina. When we say bisects the carina, the most important point is that it doesn't go through in the bronchi. Instant bronchi. So when it bisects the carina, it follows the esophagus anatomy and goes down and
to the gastroesophageal junction.
Abdomen through the gastroesophageal junction. So the tip is here. Is this satisfactory? So if they ask you, send you this X-ray and tell you, can we start feeding the patient? What do you tell them?
أستاذ هذا يصير يعني high in position.
Yes.
يعني هو just يعني نسوي له push down يعني شوي أقل مو هذا الليفل هذا يعتبر high level.
Okay, yeah, the normal level would be like nearly about 10 centimeters.
يعني reach to the fundus. يعني.
Yes, yeah, it goes 10 centimeters from the gastroesophageal junction.
نعم أستاذ.
Why do we want it to be really that deep inside the stomach, not here?
يعني إذا على هذا البوزيشن وينطونا مثلا feeding could be cause reflux.
Yes, and this would lead to
aspiration.
Great. Okay, thank you. So any other line you can see? This one here?
أي شفته.
What's this?
يعني هذا أعتقد يعني هذا site of IVC could be يعني filter.
Yes, it's a central venous catheter through the IVC. But if the patient had a central venous line through the superior vena cava, what is the normal level?
أستاذ هو ال IVC filter يعني يصير يعني
No, filter, sorry. I mean through superior vena cava, central venous catheter superiorly. And this superior vena cava, where do you want to see the tip of the catheter?
أستاذ يعني يصير enter the line through the SVC reach to the right atrium.
Cavo-atrial junction, right?
نعم نعم.
Yes. So the normal level is, this is the carina here, 1.5 centimeters above the carina, and from that point to
نعم
2 vertebral heights below the carina, that's acceptable level.
نعم أستاذ.
And it would be acceptable if it is within this range for short-term use. If it is a PICC, if you want to preferably inserted central catheter, you want to use it for longer time for chemotherapy, you would have it at the cavo-atrial junction. If you have a central line for hemodialysis, you want to see it inside the right atrium, but not touching the wall to avoid arrhythmia. And also, you don't want to have central line higher up in the superior vena cava of the brachiocephalic veins to avoid thrombosis. Is there a difference if the line is coming from the right side or the left side in terms of?
نعم أستاذ. If the left on the left side, it's indicate persistent left SVC.
Yes, but if it passes normally through the brachiocephalic vein and goes here into the lower SVC, do we want to have it lower or higher compared to the right side catheter, for example?
يعني أستاذ هو not higher not lower حتى يكون يعني open to the coronary sinus يعني الopening مالته.
Yeah, coronary sinus is on the left side.
نعم أستاذ.
That's when we have like a, double.
نعم أستاذ.
But not like in normal anatomy. My point is that you want, if it is coming from the left side, you want to have it lower at the cavo-atrial junction and its tip directed inferiorly, because according to the anatomy, the catheter would be inclined to touch the wall, the lateral wall, because it's coming from the opposite side and may lead to erosion and injury to the vessel wall. So we needed to go a little bit lower at the cavo-atrial junction, and we want it to be directed downward. That's my point. Thank you so much. That was great. And I hope now, do you see my presentation again?
نعم أستاذ.
Good.
لا بعد ما طلعت.
Okay, I need to do the same thing maybe. I'm going to share again. Okay, good. So the points we want to see when we look at a chest radiograph, we want to have a system going from mentioning the technical factors, then any tubes and lines, and then the lungs, the airway, the heart mediastinum, highland, the hidden areas, which are the apices of the lungs, the hyla, retrocardiac area, below and beneath the diaphragm, and then go to the bones, and then externally the axilla and shoulder and neck. The appropriate placement for lines and tubes, we need to know that and know the possible complications. Endotracheal tube, as we mentioned, the tip 5 to 7 centimeters above carina. NG tube bisects the carina, tip 10 centimeters distal to the gastroesophageal junction. Central venous catheter, we mentioned a lot of details, but tip at lower SVC, cavo-atrial junction. Chest tube, tip toward apex pleural cavity for air and toward the base for fluid. And we need to have an idea about the pacemakers and other electronic devices. Now we're coming to our next case, which is a big case. It's the presentation of this patient. She's a 57-year-old female. She presented with hypercalcemia, and they mentioned that this is the actual history received. Pumped head on headboard of bed. That's quite poetic. 3 months ago, and developed lump on her head. And now she has reduced Glasgow Coma scale and confusion. In addition to that, she has cough for the last 12 months.
دكتورة لينشي.
نعم أستاذ.
تفضلي دكتورة لينشي.
بس ما يطلع يمي.
Yes, I'm gonna, sorry about this technical difficulties. I hope you can see the chest X-ray now.
Yes.
Okay, good. Start, please.
أنا AP erect chest radiograph of a mature patient. There's no rotation. The exposure is good. And it's inspiratory film. Actually, at first look, I'm not.
I agree with you. I agree with you.
Anything abnormal.
Okay, good. I agree with you. That's why we need to do what?
يعني
we need to compare to any previous images, right?
Yes.
Okay. This was nearly, I think, 10 years ago for the same patient. Look at the lung fields, upper zone, mid zone, lower zone on either side, and see if there is any difference, if there's any opacification, airspace disease.
There is ill-defined opacity in the right lower zone.
Here, right?
Yes.
Okay. And
well, not seen in the previous film.
Exactly. There might be some increased density of the hilar structures here, but that's not easy to see. But definitely there are some foci of ill-defined airspace disease here. So that's one thing. Now the patient, that was just mentioned that nothing specific reported on this X-ray. And since the patient had a head injury, so still you can see, right?
Yes.
Okay, good. Since the patient had head injury, of course, the patient had a brain CT. I'm going to show it to you now. Start describing.
On the brain, can I see bone window?
Okay, that's great.
Okay, there is a left occipital hyperdense hematoma, subgaleal hematoma, and there is multiple lytic lesion within the cranium, variable size, distributed randomly.
Perfect. So what do you think?
According to the history of hypercalcemia and multiple lytic lesion, it may be a case of hyperparathyroidism.
What about the lung lesion?
Lung lesion, actually.
Let me remind you of the history. She had cough for 12 months.
It could be a tumor, like a tumor, a cancer with bone metastasis.
Okay, that's good. And sorry, just want to show. Is this a metastasis?
No, it's I think it's a site of trauma. It's a subgaleal hematoma.
Okay, didn't resolve for 2 months. So definitely the suspicion was we have something bad in the lungs. So we had CT
scan
of the lungs. Just about. So the hypercalcemia was related to the extensive bony metastasis, right?
Yes.
That's the explanation of hypercalcemia here. And do you see, what's the main, can you see the main lesion? And tell me where.
Can you go down, please? Another time scrolling it.
Yes, no problem. Focus on the right lung.
On the right, bilateral basal subpleural ground glass opacity is noted, and there is, I think, obliteration of the right lower zone bronchus. Could be an endobronchial mass lesion.
Let's do this. Let's
Also
do
on
this.
bone window, I think the posterior ribs, they have lesions.
You're right.
Yes, multiple rib lesions.
Okay,
And
so
multiple mediastinal lymphadenopathy.
we'll come to that. But when we see metastasis, we look for the primary, right? And vice
Yes.
versa. So first, I want you to tell me where is the primary, and then we can talk about this later.
Here's right lower lobe central bronchogenic mass,
Yes.
obliterating and narrowing the bronchus.
Good. So this is, we suspect that this is the primary tumor here, right?
Yes.
Okay, let's go back to the lung window. We'll come back to the lesion. I want you to tell me your opinion about this lesion here.
Yes. There are a few ground glass nodules with this one, especially the right lower zone, is a speculated margin and central low density area.
You said speculated.
Yes.
Well, I mean, yes, maybe here, but this is mainly. So tell me the type of this nodule. Is it solid, part solid, or ground glass?
It is ground glass.
Is there any solid elements?
Actually,
You might think that the dense structures are vessels, but if you trace them, you can't find, especially this one here. If you trace that, it's not convincing as a vessel, right? And maybe there are others few. My point is that if it is totally ground glass, it's a different thing than if it is ground glass plus the development of solid elements within the lesion. This is very important. Why? Because this could be a part of the spectrum of adenocarcinoma. So if you have a stable ground glass lesion, less than 5 millimeters, that could be like a typical hyperplasia. If it is between 5 and 30, it could be adenocarcinoma in situ. But if there is any solid elements, if it is less than 5 millimeters, solid elements could be minimally invasive adenocarcinoma. All of these were called bronchoalveolar carcinoma. Now they are called adenocarcinoma. And this is important. Another feature is important is these dark things here, lucencies associated with the lesion. This is also another suspicious feature of adenocarcinoma, which we call the nodule here a pericystic nodule. Ground glass with the lucencies, small cystic lucencies, and then the development of small solid elements. That's a suspicious feature. So we go back to any previous imaging and compare if it is stable. Because why? Because some of the ground glass nodules are inflammatory, right? And they could disappear within a few weeks. So, but if they are stable, at least 3 months, or any like a previous CT 1 year, 2 years ago, this means this could be a potential adenocarcinoma. And we need to follow that, okay? So another thing I want your opinion on is this nodule here.
This one is a fissural nodule. Normally, in normal situation, we fissural nodules is most likely benign nodules.
Okay, that's perfect. Cleared that. Now, so we have, this is the primary lesion.
Yes.
And so you think now, most likely, this is a carcinoma.
Yes.
And in your report, you want to provide the necessary information for the clinician to have the staging of the lesion, right?
Yes.
What information you need from the scan to achieve this purpose, to get the staging? Size
of the lesion.
Good. I can tell you that this size, it is like 34 millimeters. So this makes it like T2A or TNM classification. So that's cleared now. We got this. We need to focus on the lymph nodes.
Lymph nodes, yes.
I'll go from above and go downward, and let me know if you see abnormal lymph nodes.
Yes, we have left side supraclavicular, right supraclavicular, I think, this one.
This
Just
one.
beside thyroid gland, yes.
Which station? Level.
Supraclavicular, upper mediastinum.
No, neck levels. Like, is it
Neck level, it's lower station, last station, and I think 7.
Oh, this is the cricoid
Upper
cartilage?
mediastinum.
No. So the level we have 2, 3, 4. The ones that are below the cricoid cartilage are 4. See this one extends here?
Yes.
This is level 4, neck lymph node, which is also called medial supraclavicular. Okay. So if this lesion quite is like, rounded and looks pathological and density, just by this node, give me the N stage.
This lymph node is not regarded as N, it's regarded as M,
Why?
because it is not in the location for bronchogenic carcinoma. I think it's regarded as M.
Mm-hmm. So N1 is the hilar.
No, N3.
Yes, okay, you're good now.
Yes,
So N1
N3
is
is supraclavicular lymph node, N3.
Exactly. So just by this node, you knew that's N3 without even looking at other nodes, right?
Yeah. Yes.
Because, so N1 is the hilar on the same side, right? We have
Right.
them here. And
N2 is mediastinal or subcarinal lymph node.
exactly,
And
because
N3 is
subcarinal could be
contralateral.
considered either way. And if there is any contralateral lymph node, whether in hilar position or mediastinal or supraclavicular other side, that's N3. So we have here, we have a upper right paratracheal, we have lower left paratracheal, we have subcarinal, and also we have this one, the extension. Yeah, okay, good. And now we saw different rib lesions, right?
Rib lesion, vertebral lesion.
Great. And let's go back to the abdomen.
Adrenal, yes. We should look for.
Okay. Suspicious adrenal here, right?
Yes.
Suspicious probably here, but anyway, what about the liver?
Liver, yes, there is multiple hypodense lesions, hypoenhancing, most likely metastasis.
Here. And as we can see, there are many lesions here, and like the chest wall, and as we said, the liver, adrenal. Also, they have some lymph nodes in the upper abdomen.
Yes.
What do you call them? This one here. This is inferior vena cava. This is the portal vein. This is inferior vena cava, right? Porta cava lymph node.
Yes.
Okay. Porta hepatis lymph node.
Peripancreatic.
Good. And also lesions here. So now you provide. So what's the stage for the M?
M1B. Because M1A is the inside the thorax, like pleural pericardial involvement, or in the opposite lung. But when it is involving any extra thoracic system, it is regarded as M1B.
What about M1C?
M1C.
Yeah, let me tell you something. If it is only single distant metastasis, it is M1B. If there are more than one distant metastases, it is M1C. Of course, we have many of them, right? So it is M1C. And so that's usually here when we have these cases, we discuss them at multidisciplinary team meeting. And so they knew, you describe the case to them, you tell them the patient had this and that, and this is the staging, you show them the lesions. And the other thing they want from you is the potential route for biopsy. So if I show you this image here, from this image, what are the potential routes for biopsy?
You mean any route of biopsy?
Yes, any lesion. Just give me your.
We can take from lymph nodes.
Okay, we can have a neck ultrasound, do ultrasound.
Yes, by ultrasound guided lymph node biopsy.
And then we have a big lesion here.
Yes.
It's
Also can be
accessible.
done under ultrasound.
Okay, let's go into the thorax.
The thorax we can by endobronchial by
Exactly.
endoscopy. They can
Yeah,
take
we have-
from the lymph nodes, also from the main mass.
And what else in the thorax?
We can take from the bones by CT guided biopsy.
Great. What else in the thorax? Yeah, like ultrasound, endo. Said endobronchial.
Yes, yes, EUS also.
Exactly. Esophageal ultrasound also. We can access the subcarinal
The lymph nodes.
and other ones. Okay. And in
the abdomen.
another patient, we have the liver too, if we didn't
Yeah.
have any other potential sites. And of course, we have many superficial lesions. Yeah. So thank you so much, doctor. That was really excellent.
Thank you.
Thank you. Let's go back to our presentation. So when we look at a case of possible lung cancer, any chest CT, if there is any suspicious nodule, we need to differentiate between benign and suspicious nodules. And we need to always compare with previous imaging if available, not only the most recent study, because sometimes the difference is very subtle between one and the other, like 2 successive time points. We need to go back maybe 1 year, 2 years, to be able to appreciate the difference. And when we measure the nodules, of course, volumetry, sometimes there are AI software that can provide you with the volume of the lesion. It is always better than diameter measurements. And we need to review the scan, as we said, for staging information. And we need to follow the pathway we have for lung nodules. There is a plan, there's a pathway, we need to follow it. Maybe, I don't know if you have worked with this Brock model and Herder model. I'll explain more about them later. In addition to that, in the MDT meeting, we need to establish the fact that this lesion is suspicious for malignancy. If we need further imaging, provide the staging and the best route for biopsy. The benign nodules, what we need to exclude right from the beginning, the peripheral nodules, which are intrapulmonary lymph nodes. So if we have typical peripheral nodules, that's most like nearly 100% benign. We don't need to follow them. We don't need to worry about them. Other nodules with benign content like fat or benign calcification like hamartomas, chondromas, and granulomas. And we need to rule out vascular origin like AVM using MIP. The peripheral nodules are fissure-attached, homogeneous, solid nodules that have smooth margin with an oval, lentiform, or triangular shape. Other people describe them as also, they have usually less than 10 millimeters. They could be also subpleural, have also triangular, what we call polygonal. Because the shape is not only triangular, polygonal, they have different sides, and mainly below cranial level. Some of them we may call atypical when it meets all the criteria, but it's not visibly attached to the fissure. Sometimes the fissure is absent or too thin to be visible, so we don't see the fissure. We see atypical. Sometimes it's fissure attached, but convex on one side and rounded on the other side. So if it is atypical, we need to follow them. They're still most likely benign, but we need to follow them. And we need to remember that since they are lymph nodes, sometimes they grow, reactive inflammation, infection. So we need to follow them going back to their normal size. This picture shows the typical peripheral nodule. It's a polygonal, all triangular or lentiform. The atypical, sometimes, especially in subpleural location, we don't see the fissure, but still the same shape. Or here, it is slightly flat here, and here keeps the same shape, rounded on one side. The non-PFN or suspicious, of course, is speculated. If it is just touching the fissure or growing through the fissure, acute angles here, it doesn't belong to the fissure, and it is totally rounded on both sides. That's non-PFN. That's a suspicious nodule. We need to do further management. These are typical peripheral nodules. We don't need to worry about them. Lentiform, oval, elongated, centrally attached to the fissure. This one also clearly solid, homogeneous, and triangular. This one, it is not a typical one. And it is really suspicious because it attached to the fissure on just part of its diameter, but the other one is totally rounded. And this lesion proved to be an adenocarcinoma. But when you see this, we can say, and also it's larger in size, that's clear. So we deal with this as any suspicious other nodule. Suspicious nodules features, speculated, large size, old age of the patient. It has suspicious growth rate. The growth rate between 20 days to 400 days, that's the range for suspicious lesions for cancer. Less than that could be inflammatory, infective. More than that could be adenocarcinoma, because adenocarcinoma is slowly growing. Of course, smoking, upper lobe location is also suspicious. Other suspicious morphology, thick-walled cavitary nodules or cyst-associated nodules, as we mentioned, suspicious for adenocarcinoma. Of course, emphysema and history of cancer. So this pathway is adopted by the British Thoracic Society, and it shows how we deal with nodules, whether solid or subsolid. So if it is less than 5, we don't need to follow them. If it is between 5 and 8, we do surveillance, we follow them. If it is more than 8, we do the Brock model, which is a score calculated and give us a percentage of the likelihood of malignancy. This is the Brock calculator. We insert the nodule size in millimeter, whether it is 1 nodule or more, the nodule type, ground glass part solid or solid, the location, speculation presence or no, and the age of the patient, the gender of the patient, family history of lung cancer, emphysema, and gives us a score. If it is more than 10%, that's suspicious. So we go back, more than 10%, we send the patient to PET-CT. If it is less than that, surveillance. For PET-CT, we use a similar model called the Herder model, this one. Also some criteria, like age, smoking status, previous history of extrathoracic cancer, size, location, speculation, and PET avidity. So this is the score for the same patient, which was 67.7 here. And because there is no FDG avidity, it went back to 10. So then, if it is less than 10, we go back to surveillance. If it's more than 10, as our patient here, between 10 and 70, we consider biopsy for this lesion. If it is more than that, we continue the management also. We go for treatment, surgery, biopsy, and also, of course, this is at more risk. If we have the lesion here for surveillance, we see if it grows or not. VDT, this is the volume doubling time. If it's less than 400, we go this way. If it is between 400 and 600, also we need to follow it. If it is more than that, slow growing with discharge, it's slowing. That's a slow, and it is solid nodule and didn't grow in 600 days. So that's more likely benign. But if it is subsolid, also we follow that. The only difference here is that we don't do PET-CT for subsolid nodules because, as you know, ground glass, they're mainly ground glass. They wouldn't show any avidity. So we do the Brock model and follow from here. So that's a brief description. I know that's it's hard to cover the whole subject in a short session like this, but I hope this provides you with an idea of how we manage suspicious lung nodules and lung cancer. The third case is of a 46-year-old male with right-sided chest pain.
دكتورة أسيل.
نعم أستاذ. صباح الخير.
تفضلي. أنا تمام.
Okay, so this is a 46-year-old male patient presented with right-sided chest pain.
نعم أستاذ. Frontal X-ray erect patient of skeletally mature patient. There's opacification and with obliteration of the right costophrenic angle and obliteration of the right diaphragm, hemidiaphragm.
Good. So there's airspace disease and suspicion of pleural effusion, right?
نعم أستاذ.
Good. So when they saw this X-ray, they requested CT scan. I'll show you the lung window.
increase بالinterlobular septal thickening,
Mhm.
bronchiectatic changes, bronchiectasis, with consolidation, peripheral located, mild pleural thickening.
Yeah, so we saw the abnormality on the right side, right?
Yeah, on the right side, yes.
Good.
Right lower.
We'll focus on this area here, and I want you to focus on this lesion here.
Mm.
What kind of description you can give to this lesion? Is it total airspace opacification, i.e. consolidation, or there's ground glass opacification within it, or what?
Ground glass.
Yes,
There's
ground glass
another
in the center mostly, and the periphery it has high density.
high density peripheral with central ground glass. يمشي ويا ال reverse halo sign.
Mhm. Now, so when we evaluate the CT chest, we do let's assume that we finished the lungs, okay?
نعم.
What other structures you need to evaluate?
يعني beside the lungs, mediastinum.
Yeah, okay. Have a look.
Can I follow the right main bronchi?
Okay.
ال
Other structures.
there is
Other structures other than the bronchi.
vessels.
Okay, yeah.
I see there is soft tissue nodule. Yes, this one, the right hilum, between the bronchi,
Mm-hmm.
between the main bronchus and the right upper.
Okay. Which structure is this? So this is the right pulmonary artery, right?
Main pulmonary artery.
Here, this is the upper
Suspicion
lobe.
of a thrombus.
Okay, where?
دكتور لحظة. And the right pulmonary vein.
Follow them. This is the interlobar artery, and gives the branches to the middle lobe artery and lower lobe artery. And
نقدر نشوف إيه هي thrombus.
Yeah, where? Follow the lower lobe artery.
إيه follow the lower.
Here, right?
Subsegmental.
Yeah, segmental and subsegmental mainly, involving medial, basal, posterior basal, and also subsegmental, maybe involving the lateral basal. So we have, so what's the overall impression now?
هي pulmonary embolism أو عندنا cause distal pulmonary infarction.
Great. Of course, as you know, this is a CT chest with contrast. It is not a CTPA, right?
No.
So I reported this and mentioned all the changes. But for the proper evaluation of
also لازم أشوف.
Yeah, it's nothing is remaining of the remaining structures are abnormal. So proper evaluation of a pulmonary embolism, we do CTPA, right?
CTPA angio.
Okay, this is CTPA for the same patient. done later in the day after my report. Just wanted to confirm that we have
موجودة إيه.
pulmonary embolism with infarct. And it's clear, right?
إيه.
Now let's
هنا
talk about, yeah,
Excellent.
so it's obvious now. And we can also see, we want to talk about the proper way of evaluating for pulmonary embolism. First thing, we need to check the technique. We need to see the density. I don't know if I can.
Density مال pulmonary artery.
Exactly. We need to have a
يكون higher.
So what do you think of this level of opacification of the pulmonary artery? Is it satisfactory? Is it
يعني
optimal?
satisfactory.
I think it is not, because the level, if it is below 250, that's suboptimal. And you know why? Because this affects the
Timing.
Yes, you can't exclude emboli in the distal arteries like subsegmental, segmental, and probably lobar. And this is one thing you need to check. It should be 250 and above. The other thing,
measurement الدايمتر مالته لازم below الأيورتا يعني aorta larger.
yes, this is for right heart strain. But before that, for the technique, we check the density in the pulmonary artery. Also, we check for any respiratory artifact that could obscure the visibility or lower down in the line. And then after we established there is a pulmonary embolism, of course, we need to know is it chronic or acute. How do you differentiate between chronic and acute emboli?
نقدر نعتمد على السايز. السايز إذا collapse والأوريو ساين، وأيضا إذا مثلا partially collapse، إذا الفزل not completely opacify، هاي chronic يمشي وياها. الأنجل أيضا إذا acute chronic يمشي أيضا.
Here the pulmonary trunk is not larger than the aorta, and the range is 32 plus minus 4, so it is borderline. Also, now checking for the right heart strain, okay? Dilatation of pulmonary artery. You check the septum if it is deviated to the left or straightened. And what's the best way to evaluate for right heart strain?
measurement مال interventricular، السايز مال right ventricle and left ventricle، ومقارنة الشيب مال left ventricle.
Exactly. If the RV diameter is larger than the LV diameter, that's an indication of right heart strain, which is not the case here. Which is not the case here. And naturally, because of the small size of the emboli, right? It's only subsegmental, segmental, and a small part of the line. We don't expect to cause a lot of exactly a lot of pressure to cause strain. Last point is any associated features. So we mentioned we found an infarct, right? Found an infarct.
نشوف إذا أكو distal infarction.
Good. And if there is any other abnormality within the line. Okay.
هم mention it.
Okay. Thank you so much, doctor. That was excellent.
شكرا.
And to apply our knowledge, we wanted to see another patient, another student, please, if they can volunteer. The second case, same subject.
دكتور سيزار موجود؟
نعم أستاذ، صباح الخير.
هلا صباح الخير، تفضل.
Okay.
This patient presented with the same presentation, sudden shortness of breath, right-sided.
Okay, this is a frontal chest X-ray of 91 years old male. The exposure of the chest X-ray is good. No frank rotation.
Good.
And I think it is inspiratory film.
Good. Well, there's a little bit of rotating, but no problem. That's not our issue now. Do you see any clear abnormality in the lower zones?
Okay, there is a opacity in the right lower zone. It's tubular in shape.
Good. How do we confirm that?
I would like to see either lateral chest X-ray or previous chest X-ray.
Okay. Oops. Two. So, by the way, this X-ray was reported normal. When I saw it, I didn't agree with that. And I wanted to go back and see. Let's see, I think we have an older one, yes. So this is the older X-ray, just 2 months before the one we have right now.
The abnormalities doesn't exist in the
Yes,
previous.
exactly. See here, it's not, the opacity
Yeah.
is here and continuous with the vessel. It could be suspicious of, and as we said, the acute embolism caused expansion of the vessel and caused more density. So this is what's on the X-ray, and then.
So you'd like to do CT scan for this patient, of course.
Yes. See now, let's go to the. So first, as we agreed, technique, CTPA. What do you think of the opacification of the pulmonary trunk?
We have to measure the density of the pulmonary.
Good. It's higher than the aorta, and of course I can't say no, but it's clear. I mean, if that's good, just to confirm.
So yeah,
560. That's very good. And
so
now
there was diffuse emphysematous change.
Okay, that's great, but we need to focus first on our main job here, which is see if there's any pulmonary embolism, right?
Yes, and yeah, I can see the prominent of the there is a large filling defects in the right main pulmonary artery and its bifurcation.
Good. Involving
the upper lobe pulmonary artery and the lower pulmonary arteries.
This is the upper. Can you see it? There is no filling defect in the upper lobe artery. So this is the main artery.
Yeah, starting from here.
Yes.
Starting from here, or going downward, and then more downward until the.
Involving both the middle lobe arteries and the lower lobe arteries, right?
Yeah.
And causing expansion of the lower lobe arteries. That's right. That's what we saw on the chest X-ray. And with the size of the embolus, do we expect to find any right heart strain?
Yeah, actually, we have to go back and measure the main pulmonary artery and aorta. So it's more than one. So I expect pulmonary hypertension.
Good. And if we measure.
Yeah.
That's clear, right?
So again, more than one, the ratio is, so I expect heart strain is present here.
Other sign here?
Okay, there is.
This is the right atrium.
And it was superior vena cava. Okay, dilatation of the right atrium.
What happened to the inferior vena cava? Is there
no to see.
There's reflux of contrast into the inferior vena cava, which is also an indication of right heart strain.
That's right.
Another sign
of the strain of the heart.
Good. So we covered technique, we covered the embolism, we saw if there's right heart strain, and now we need to see if there's any other structural abnormalities within the lungs, other than what we have described.
Like complications like lung infarctions.
Good. Look at the upper lungs.
Yeah, it's totally, there is emphysematous change, central lobular in the both upper lobes, I can notice.
And here?
there is a bronchiectasis change in the right middle lobe.
Good. Bronchiectasis.
So I think the patient
mucus
has
plugging.
also COPD, like chronic obstructive lung disease, maybe because of these findings, emphysema and bronchiectasis change.
Sorry,
Okay,
can
there
you
is nodule also in the. Sorry, doctor.
Yes, well, what's your conclusion?
There is a bronchiectasis.
You mean a unifying diagnosis? Sorry, I couldn't hear you. Can you hear me?
شيزار ويانا.
العفو استاذ انقطع الصوت.
No problem.
تفضل.
Okay, there is a small nodule in the right lower zone, right lower lobe as well, in the posterior segment of the right lower lobe.
Yeah. So these are not connected. So the patient
Okay.
had bronchiectasis, inflammatory
diffuse
nodularity, bronchiolitis, and this is more likely an inflammatory nodule here. And yeah, emphysema, and we have described all the pulmonary embolism. That's it all for this year. Thank you, doctor. That was excellent.
Thank you very much.
Let's go to the presentation. Okay, for pulmonary embolism, you need to keep in mind the technique as we mentioned here, and no respiratory artifact. We need to mention the arterial level emboli can be excluded. So we can say clearly that we can exclude. If for some reason, if there is the attenuation is not perfect here and there is artifact, you can see, we mentioned that we cannot exclude emboli at smaller arteries like lobars. We need to mention that to be clear, just to, you know, mention the whole situation about the study itself. And we use multiplanary reformatting to systematically review the arterial system. Some people advise using wide window settings to help avoid the obscuration of small emboli. And we need to also to make sure that the filling defects are in the arteries themselves, not in a poorly opacified vein or like a bronchus with the mucoid impaction. One point I want to mention about this case is the following. Just want to show the correlation between. We said we need to follow the pulmonary arteries on coronal and sagittal just to be sure we follow all the arteries. And here we can see the correlation that the artery is expanded by the filling defect, which causes this appearance on the chest X-ray. Now we'll go to the fourth patient. Let me see.
دكتورة فاتن.
نعم عمي صباح الخير.
صباح الخير. تفضل.
I'll show you first the chest X-ray of this patient. Make sure I have the dates. This patient is presented with long-term shortness of breath. I think the older one. Yes, this is the one that's right now present. Yes. So yeah, start your description, please.
Yes, this is an erect frontal view chest X-ray of skeletally mature patient. It is technically acceptable. Seems to be of good ventilation. There is an obvious pacemaker or no implanted in the left side, left upper chest. with the pacemaker leads seems to be bi-lead.
Okay, sorry, I have to interrupt you.
Maybe,
Is this a
maybe,
pacemaker or another device?
maybe. However, we have many devices implanted in this position. Maybe implantable cardiac defibrillator having 2 leads.
Can we differentiate
Yes.
ICD from PPM, the ICD from pacemaker?
Yes, I think from the exact wires and the attachment to the apparatus. Let's see.
Okay, so
yes.
this is a dual chamber device.
Yes.
There is
leads.
a lead inside the right atrium, another one in the right ventricle, right?
Yes.
This happens both with pacemakers and with ICDs. But the main difference is here, this structure here, and this structure here. When you see these wide, opaque structures along the lead itself, which is different than the normal, thickness of the. This is not present in the pacemaker. This is present. Sorry.
ICD device.
What's the name of this band here?
I'm not sure.
Shock coil. This shock coil, because it's ICD, it defibrillates. So the patient has arrhythmia. Shock coil here, shock coil here. That's the main idea of defibrillation. So when we see the shock coils, we say this is an ICD. And I mention this because it's relevant to our case.
Yes. Is there also opacities, in the peripheral-based opacities in the right middle lobe?
Okay.
Some sort of cardiomegaly, mild cardiomegaly. And also there are some calcified plaques right in the diaphragm, pleural base. Yes. With mild cardiomegaly. Yes.
Okay. I'll show you the older chest X-ray.
Yes.
Is it the same ones?
Yes. The same plaques, diaphragmatic base plaques, present in both X-rays, opacities in both, larger opacities in the right middle lobe compared to the previous exam.
I agree with you.
The same position of the ICD leads. Yes.
So throughout these 8 years, the pleural plaques, the calcified pleural plaques have enlarged, right?
Yes.
And you can see here also projected over the right lung and here. So they have enlarged. Nothing changed for the ICD. Now let's go. So they requested a CT chest to see what's happening with this patient. Sorry. I'm going to show you the lung window first.
Yes, multiple calcified plaques, bilateral, pleural based. Pleural thickening, bilateral, obvious pleural thickening with the.
Sorry, I have to apologize.
Multiple scattered calcified plaques.
Yes, this is the older one. I'm going to show you the newer one. Sorry. We'll come back to that later. So the same as you described, there are bilateral pleural plaques. And here.
With also paraseptal emphysematous changes.
Why do you think it's paraseptal emphysema?
We have bleb-like.
Okay.
Or even
focus on this reason.
Fibrotic changes, honeycombing, yes. So fibrotic insult, maybe interstitial lung disease, yes.
Okay, now
we have fibrotic, multiple. Yes, also we have traction bronchiectatic changes involving both lung bases.
Okay, I'm going to ask you to describe the elements of the interstitial lung disease here. Fibrosis and non-fibrosis.
We have all the elements of interstitial lung disease. Exactly in this case, we have honeycombing, bilateral, more predominant in the right lower lung base, and also have multiple atelectatic bands, fibrotic bands. We have the third element, which is the traction bronchitis, is more predominant in the right lower lung zone.
What about
All
the
of these?
distribution?
Also the left lung base, but more predominant in the right lower lung base. Also have the calcified plex. So it is mostly an interstitial lung disease, could be related to the pleural plex, may have an asbestos exposure or other.
Yes. So
Yes.
there's bilateral, peripheral, subpleural, predominantly basal reticulation. Okay, with honeycombing, as we said here,
Yes.
the middle lobe, lingula,
Yes.
slightly,
Yes.
and also posteriorly, in the right lower lobe. And
Yes.
that's honeycombing is the evidence of fibrosis.
Yes.
And traction bronchiectasis and bronchiectasis that are evidence of fibrosis. So a fibrotic interstitial lung disease, of which pattern?
Mostly with the usual interstitial pneumonia, or called idiopathic pulmonary fibrosis.
Okay.
This is the most common pattern. Yes.
We say, are you right? It is a typical UIP pattern.
Yes.
If there is no cause, that's.
If no cause, this is called idiopathic pulmonary fibrosis.
And if there's a cause.
Yes. Yes.
So what's the final diagnosis
here? We have mostly it is related to the calcified plex, may have any history of working with the asbestos or something like that.
No,
we don't have.
calcified pleural plaques bilaterally, in this case, in an old age patient, is an indication of asbestos-related pleural disease.
Yes, old infection could be old. Yes. So mostly in this case, usual interstitial pneumonia or idiopathic pulmonary fibrosis.
The final diagnosis is it idiopathic pulmonary fibrosis or a secondary cause?
I don't think it is an idiopathic. It have a cardiac disease, as we said.
No, I mean you have ILD pattern typical of UIP, and we have asbestos exposure. So the final diagnosis, connecting these points together, is in one word.
يعني انه usual يعني الانترستيشال نيمونيا هو
No, just keep it simple. There's asbestos fibers causing damage to the parenchyma. So the disease is
interstitial lung disease. يعني we can give it a broad term.
What's the differential of UIP pattern in the lower lungs?
And the lower lung, we could have non-specific interstitial pneumonia. Yes.
Just listen to me. We identified the pattern already. We said it's UIP, typical UIP.
Yes.
We identified the distribution that's in the lower lobes, lower zones,
yes.
okay?
Yes.
And we have the differential for typical UIP in the lower lobes. If it is not idiopathic, it could be either connective tissue disease.
Yes, connective tissue disease related, or could be occupational, or even asbestos-related asbestosis.
Yeah, give me one word.
Asbestos.
Yes.
I don't have the exact history of this patient. If it is asbestos, have any asbestos exposure, we call this asbestosis. This is an asbestos-related interstitial lung disease. We don't have the exact history. So
I see, but in terms of occupational lung disease, the disease that causes this kind of bilateral pleural plaques is most likely
asbestosis.
Right?
This is an.
It is not silicosis
we have plaques
or pneumoconiosis.
plus pulmonary fibrosis. Yes.
Exactly. So it is asbestosis. Okay. So now, are you satisfied? I mean, just to make it simple, we need to look for other things, right?
Yes.
So if we have part of the abdomen visible, we need to have a look.
Yes.
Have a look at the abdomen here.
May have some sort of hepatic fibrosis, irregular outlines of the liver.
That's one element. You're right.
Irregular outline of the liver may have some sort of hepatic fibrosis or cirrhosis.
Good. That's the contour of the liver. What other elements in liver evaluation we can comment on?
Density, hyperdense liver. This is you can measure the density of the liver.
Good.
May have an arrhythmia. Yes, this is mostly an arrhythmic patient. Yes, this is a hyperdense liver. May have an maybe on treatment for antiarrhythmic treatment. This is mostly in cardiac disease, having hyperdense amiodarone related hyperdense liver disease.
And now you can see why we focused on ICD versus permanent pacemaker. And
yes,
now, when I saw this patient, they were asking only about is there is ILD, and that's it.
yes.
So we have asbestosis, and we have another reason causing also within the differential diagnosis of lower zone UIP pattern, which is amiodarone toxicity. Because the patient had arrhythmia, is ICD since 2015, and we have clear, look at the difference between the density. Usually the liver is between 50 and 60 Hounsfield,
Yes.
and only within like 10 Hounsfield denser than the spleen,
Yes.
but the difference is clear.
More than 40, yes.
How can we confirm?
Clear.
Okay, so now we go back to the main basic element. We need to compare, right?
Yes.
Okay, I'm going to show you an old CT. That's 2015, 8 years before. But this is also with contrast, but you can see clearly that the liver contour is fine. And if we measure the densities here, there is no big difference between the spleen and liver, both taking contrast, right?
Yes.
But here, this is non-contrast, and we clearly see that
we have obvious difference in density.
Yes. What's the upper limit of the density of the liver? Well, after that, we can see hyperdense liver.
It's normally it's within the range of 50 to 70, I think, and no more than 75 with the upper normal.
If it is more than 75, we can sure. What are the causes? The causes for hyperdense liver in general.
Hyperdense liver, we have any element of deposition like iron deposition, Wilson, hemochromatosis, amiodarone, one of the causes, amyloidosis. All of these are causes of hypertension.
Yeah, there is any exposure to metals.
Yes, metals.
Iron, that's hemosiderosis, hemochromatosis. Copper, that's Wilson disease. Gold therapy. What's the element in amiodarone? That I'll show you something, a hint. Look at the thyroid. The liver has the same density as the thyroid. Because amiodarone contain iodine.
Yes, iodine.
And that's why it causes high density.
Yes.
And sometimes, in rare cases, it might cause even like a similar, like features similar to thyrotoxicosis. But anyway, so in this patient, they didn't mention anything about the liver, but of course, now we have evidence that the patient has amiodarone, has been taking amiodarone since 2015, 200 milligrams. After that, after I made the report, I went and checked the record of the patient. I found out that he's been receiving amiodarone daily, 200 milligrams. And also this cannot be ignored, and we cannot totally exclude the contribution of amiodarone toxicity to the appearance of the lungs and the fibrosis. But we need to just see this. I can tell you that CT was done before the patient had started amiodarone. Let me just erase the. Let's go. Lung. Let's compare the appearance of the lungs. So
yes,
you can't
honeycombing more on the right.
Yeah, so there was interstitial lung disease early features, right? There was some. Now it is more, but there was some suggestion like early honeycombing. There was some reticulation peripherally. That's before amiodarone started. So the main diagnosis is asbestosis with amiodarone toxicity. And the only thing now is how to differentiate between and see what's the main reason. So after that, I checked the medical records yesterday. The clinician suggested to the patient they will stop amiodarone and check after a while to see if there's a change in the appearance of the lungs. And by that, you know why? Because it's important. Because if the patient has asbestosis, this means that he needs to get compensation, and he can sue the place where he used to work and get money because they get. So it's a legal issue too, but it is asbestosis definitely, and probable contribution of amiodarone toxicity. For the liver, this could cause only an increase in the liver enzymes, but definitely if continued on the patient continued on amiodarone, it might have cirrhosis in the future, like full-blown picture. So that's our case. And let me go back. Thank you so much, doctor. That was really great. Thank you. Stop sharing. You go back to the presentation. I apologize that the session is taking longer time, but I wanted to highlight important features. So this is from our last case. You can read this later. Differentiating acute and chronic emboli and evidence of right heart strain, as we said, and associated features. So this is our patient. And here we have to keep in mind to identify the pattern of ILD. Typical UIP, probable UIP, the difference between them is that there is honeycombing, and here everything but honeycombing. There's no honeycombing, so that's probable. Indeterminate for UIP, it's can go both ways. It's just reticulation and maybe some ground glass, but you cannot say it's UIP. Alternative, when there's a clear evidence that there is evidence of another disease, like NSIP, when the ground glass is the predominant feature, there's no honeycombing. HP, when you have upper middle zones, and we have centrilobular nodules, and we have mosaic attenuation and other features. Sarcoidosis also. So this is an alternative diagnosis. We need to look for potential causes of the ILD according to the clinical information and the imaging pattern. We need to really be aware of the satisfaction of search. We need to look if there is any significant findings in other areas, and that would help us, as in this case. And we need to familiarize ourselves with the appearance of cardiac devices like the permanent pacemakers, ICDs, and loop recorders, and others. So we need to go now to our last case. This is a 77-year-old female, had a fall a few days ago, and now have left chest pain suddenly increased today. They're suspecting rib fracture or bleeding. So I'm going to stop
دكتورة هنيدة.
صباح الخير.
صباح الخير.
Let me share this one. So this is the CT of the patient. Patient had trauma a while ago, and they did this non-contrast CT of the patient. They suspect either rib fractures or bleeding. Since we're talking about rib fractures, I'll go to
the bone window, please.
Yes, I'll go start slowly from the superior aspect. Focus on the left side.
Okay.
So do you think there are fractures on the left side?
Yes, I think in these two ribs.
Yes.
Posteriorly.
Yes. No.
But I cannot count.
No, not posteriorly. It's anteriorly, right?
Yes, anterior ribber fracture. Yes, this one.
This one and this one. So 1, 2, 3. Okay. 1, 2,
Ipsilateral
3.
pleural effusion.
Yeah. Let's go to the line window. Yeah. There's some small pleural effusion.
There's a small pleural effusion.
Yeah, subjacent atelectasis
With the-
also on the left side.
Some airspace opacification.
Great. Now, that's great. So there are rib fractures. Is it important if the rib fracture is if the rib is broken on 2 points?
Yes, it is broken if more than 3 ribs broken on more than 2 points. So it is we have suspicion of the flyer chest. So it is a major trauma to the chest.
Exactly. So of course they didn't suspect vascular injury, but if we suppose if we want to evaluate for a vascular injury and we have non-contrast CT, what could we get? Like what could we get? In terms of features that help us.
In the non-contrast study,
Yeah.
you mean for the aortic injury?
Yes.
Like yes, if we have aortic injury, we have some features that could help us, like the apical pleural cap opacification of the apices, deviation of the trachea to the other side, left-sided pleural effusion.
Mm-hmm. In terms of acute aortic injury, the aorta itself.
Yes.
So yeah.
So we have some findings. These findings are the non-contrast CT study on the chest X-ray. As I mentioned, like there is a left apical pleural cap. There is indistinctness of the aortic knob or the deviation of the trachea to the other side.
Okay, what about the wall of the aorta?
There is a discontinuity in the wall of the aorta.
Yeah, not in this patient, but in general. Also, what about the density of the wall of the aorta?
You mean, yes, if there is increase in the density in the wall of the aorta, substitution of the intramural hematoma. Good.
That's great. That's my point. And also, you can see like a high density fluid in the mediastinum surrounding the aorta, the pleural cavity or pericardium, like, gives you a clue, to conclude that the patient had bleeding. Now, so that's the main thing for this patient in terms of trauma. She had rib fractures. And as we said, we need to check, for other things.
For the other, yes.
The airways, you check the airways, you make sure there's no airway injury. You check the lungs for laceration.
We can use interstitial projection on the CT to check for the airway.
Yes, exactly. I agree with you. And the patient had no problem in that regard. So we go and look into the abdomen. Is there anything abnormal in the abdomen?
There is any 2 gallstones actually obvious on the abdomen. Actually, there is no any obvious ascitic fluid present here or any obvious organ injury.
Good.
Regarding the liver and the spleen. Usually in the cases of the left-sided ribber fracture, we have to check for the spleen if there's any associated splenic injury.
Exactly, I agree with you. So the 2 gallstones are incidental finding. Yes. And when we mention them, we mentioned that the gallbladder is?
It is distended, but actually it is of the thin wall, no obvious inflammatory changes.
Great, that's the main point. And the last thing I want you to see, is there any other abnormality in this image?
There is deep to the latissimus dorsi muscle, there is bilateral soft tissue masses. Suspicion of the bilateral elastofibroma dorsi.
Good. Can you tell me more about this diagnosis?
Actually, these are the soft tissue masses usually occur in elderly patients, mainly I think in the female. Usually located has a classic location inferior to the scapula, deep to the latissimus dorsi muscles. Usually it is asymptomatic, has no significance actually, and there is no any risk of the malignancy.
You're right. There are sometimes you can see that they have nearly skeletal muscle density, and they ill-defined on the periphery, and there is some interspersed fat that you can see also evaluated exactly on MRI, and sometimes they slightly enhanced. Also, sometimes they could have a faint uptake on PET-CT, but that shouldn't worry us because they are totally benign. As you said, more in the females, like from 5 to 13 to 1 versus male, and 60s and 70s, old age. And they're related to the continuous friction of the inferior scapula with the posterior chest wall. So when we mention this in the report, we need to tell them that. And by the way, they're like 30% bilateral, and because more they said in the literature they're more likely to be unilateral, but all the cases I saw were bilateral anyway. So here we need to tell them that these lesions are, when we mention them as an incidental finding, we need to tell them that they are benign.
Benign lesion, incidental finding, yes.
Exactly, and most likely they're asymptomatic.
Yeah.
So no worries, because if somebody else that doesn't know about this, when you see the what's this? But well, that's funny, but sometimes they wouldn't be able to notice it because they are symmetrical. But because you're really observant and astute, I congratulate you on this level of observation. So thank you so much. This was really excellent. And this case, I put it here just to highlight the incidental findings we see on chest imaging, chest CT in this case. I'm going to show you my final slide. Okay, very good. So incidental finding in elastofibromatosis dorsi, we need to keep in mind that we need to have a system all the time when we analyze any imaging study, or if we don't have a system, we need to be ready to come up with a system right away, because, for example, you need to just evaluate structures from the center to the periphery, or superior to inferior, or take the viscera and then take the vessels and lymph nodes. So always be ready with a system that will help you a lot and help avoid any mistakes. You don't want to miss vital findings. Unexpected findings are hard to notice when symmetrical, as in this case, but it wasn't hard for our radiologist here. Choose wisely what you need to mention in the report. Sometimes when you're busy reporting emergency studies, you don't have the time to report any fine details that are not non-consequential and maybe not significant. And most important, you ask yourself, is it relevant to the clinical question I have now? If it's relevant, of course, we will mention it. If it's not relevant and it's not significant, that doesn't need any further imaging or follow-up, you don't have, it's like a minor thing. But if you feel that the incidental finding has a potential for confusion for somebody who's not acquainted, not familiar with this finding, mention it and dismiss it. Mention that we have bilateral elastofibromatosis dorsi. This is a benign lesion that doesn't require any follow-up or any, we don't expect any consequences or complications. And that's it. And thank you so much.